This is Professor Perez. We'll be discussing pulmonary system anatomy today in class. Uh, Here are your objectives that we'll be discussing today in class. Surface anatomy. This is what the actual lungs would look like when positioned within your body. Get familiar with the surface anatomy. Understand where the sternoclavicular joint is. That's a good landmark to go by. The clavicle, the area of the diaphragm, just at the nipple line, overlying the distal portion of the sternum, just superior to the xiphoid process. Count your intercostal spaces. Know where your ribs are located at 1, 2, 3, 4, 5 through 12. I would get familiar with your surface anatomy, not only for physical diagnosis lab, but for evaluation of patients once you get out there. This is from your auscultation pages from the Bates book. And this is showing you the actual different lobes of each lung in relation to the surface anatomy. I would get familiar with this. This could be helpful down the road for evaluating patients and also for evaluating chest x-rays. And also have an idea where the horizontal fissure and oblique fissure are located on the right lungs as well. So I would get familiar with this as well. Respiratory system consists of following structures. It begins at the nose, and for this purpose of the slide, ends at the trachea. We have continuing structures that go down to the lower respiratory tract, starting from the trachea down to the alveoli. Divides up into right and left main bronchi at the carina, which is the level right here. Show you right this area here where it bifurcates into right and left main bronchus. Then it consists of further segmentation down to secondary, tertiary, and your terminal bronchioles, and then your alveoli. These are the four major events when we conduct respiration. Basically, get familiar with terminology and what each does respective to the act of respiration. The upper respiratory tract, if you apply it to a disease such as the upper respiratory tract infection or a URI, you'll be able to understand these structures much more significantly. You have your paranasal sinuses right in here, which is your maxillary sinuses. Those are going to get congested and painful to palpation, and a lot of pressure upon any type of head movement due to the amount of mucus and backup in there. Your pharynx and larynx will also get a little bit sore and red. Inflammation will set in as well. And your nose will start to run with mucus, and so as your nasal cavity. Mucus will build up in there and create pressure on the face. Things will start to slow down. As far as lymphatic, they can't keep up with the amount of viral load or bacterial load, and things start to back up. And what ends up happening is you'll start to see a runny nose, phlegm, mucus, and that is why we have you guys drink lots of water when you have a URI to allow that mucus to continue to liquefy and flow freely out of your nose. The lower respiratory tract consists of the trachea and bronchial tree. If bacterial viruses get down lower, that's when you start seeing the much more prominent coughs, wet or dry coughs. You'll start to see different colored phlegm, and something can set in, such as pneumonia. So when bacteria or viruses get down towards the lower respiratory tract, we get concerned for possible further compromise with more serious pulmonary conditions such as pneumonia or chronic bronchitis. This is what your nasal cavity consists of. So you mentioned the paranasal sinuses. The septum divides the nares in their own respective categories. Know where the nasal terminals are located, as always. So the sinuses are there to humidify the air, but sometimes they can back up with mucus and create pressure on the face during an upper respiratory tract infection. The main job is to warm, moisturize, and humidify the air, so that way when it reaches the lungs, it's ready to be able to do its job as far as oxygen dissociation is concerned. Here is a diagram of a sagittal view of the head and face. Notice the structures that we have discussed in class with the nasopharynx, oropharynx, laryngopharynx, larynx, the dental structures, your cricoid and thyroid cartilage. I would know the difference between those two, where they're located. The tongue, as we discussed, how large it is in a human being, and obviously every other feature that we've discussed. Get familiar with this one. It's a good one to understand as well. Lower respiratory tract, it goes, as you can see in that area there, down to the lungs. So it begins at the trachea. I'm not going to have you memorize what the size of the trachea is. Just understand that it extends distally and is found anterior to the esophagus, and it also split into the right and left main bronchus. That bifurcation was mentioned right here is called the carina. Get familiar with that as well. Um, Here's an anatomical picture of the trachea. Now, excuse me. Now we discussed the trachea. We also have to locate it within its surrounding borders, adjacent structures, as we always done in lab and in class. Here we have that its inferior borders of cricoid cartilage, which is at the level of C6. That is what we press down on to allow for proper intubation of patients preoperatively. Also know that the posterior part of the trachea is like a C-shaped structure. It's cartilaginous, but in that open part was C-shaped. There's a thin muscular layer that also assists with the esophageal process of swallowing food. So that is helpful as well, but just understand that the level of the cricoid cartilage, and that is anterior to the esophagus. Notice here that this is in red and bold and underlined. It's kind of important here when you understand the structure. You can see here as a terminal bronchioles, if we go superiorly up towards the right and left main bronchi. At the carina, it bifurcates into a right main, which is going to always be shorter, wider, and much more vertical when compared to the left. So no difference between the right and left main bronchus. Obviously, you can see that it'll be a lot much easier to intubate with a vertical positioning than what you can see in the left, which is kind of curvilinear. So further subdivisions of the right and left main bronchi are into three secondary bronchi, which are also known as your lobar bronchi, and then those secondary bronchi divide further into segmental bronchi, which are known as tertiary bronchi. So I would label these structures on this diagram to get familiar with them. Here's your right main. As we discussed, it's shorter, much more vertical when compared to the left. You need to understand what level the right main bronchus enters into the thoracic cavity, and that is the level of T5. Also, there is a vein called the azygos vein, which is right here. Sorry. And understand that it'll run inferior and anterior to the azygos vein. Okay. That will further divide into a superior, middle, lower bronchi that I discussed. So key moments from this slide is that understand where, at what level the right main bronchus enters the right lung, and where it's actually located in relation to the azygos vein. Left main, notice that it passes anterior to the following structures: the esophagus, your thoracic aorta, and thoracic duct. It also splits into further secondary and tertiary bronchi. And I want you to understand that this one, your left main bronchus, enters along the approximately level T6. Okay, so right main T5, left main T6. This has numerous passageways. This schematic over here, I threw in there just to make it much more simplistic and easier to follow and understand as to the locations of all of these segmentations and subdivisions of the bronchi. I want you to get familiar with them. Primary bronchus, down to secondary, down to tertiary, down to terminal, and obviously your pulmonary lobule where the alveoli are located. for oxygen and CO2 exchange to occur. This slide here will summarize everything we just discussed. As far as the lobes are concerned, superior, middle, and inferior lobe in the right, where the first subdivisions are located. So I understand this slide well enough. This slide here will show you much more further details as to what the right main bronchus is subdivided into further, as well as left main as well. Now these colorful structures actually indicate the actual portion of the lung, the upper lobe, middle lobe, inferior lobe, where these terminal bronchioles conduct oxygen exchange. I'm not going to have you go that in depth with that. Just understand that there are subdivisions of the right and left main bronchi. Here's a schematic of the anatomage showing the picture here. This is what it looks like. Like I said, don't get too lost into the minutia with all of these right upper lobe, left upper lobe, middle lobe. What these numbers indicate. I had this in GLIC course last year, and it really just for clinical medicine, as far as our roles as PAs are concerned, it just gets too far into the minutia for it to be practical. So I'm going to not go too in depth with that. This is your segmental tertiary bronchi, where they're located. Just understand that this is what they look like. There's much more of those, as well as here's some more segments as well. This is stuff that is just for FYI. Respiratory bronchioles, so my face here is covering those, so just refer to PowerPoint. So they branch from the terminal bronchioles, and they basically go into your alveoli here to create oxygen exchange. The surrounding capillaries is where you have them coming from the left side of the heart and systemic circulation that are filled with oxygen. They drop off their oxygen, take some CO2 back up to the right side of the heart, go towards the lungs, and create oxygen exchange once again. So it's a cycle, pulmonary cycle, so to speak. Your lung parenchyma consists of the following structures: your alveolar ducts, sacs, and alveoli. It looks like a broccoli, a stalk, and floret, if you want to think of it that way. Get familiar that the fact that the pulmonary vein and artery where they're located, and the alveoli in relation to the blood capillary beds as well. You don't have to worry about the pneumocytes type 1 or type 2. Just understand that in the alveoli, there's a substance called surfactant that maintains surface tension so that the alveoli do not collapse upon each other. This is the diagram as well, which much more capillary-rich alveolar beds are located, and just showing you more detail in that regard. As I mentioned, the mucosal linings of these structures release pulmonary surfactant. We discussed in class briefly of a TV show called Bates Motel, where one of the characters suffered from cystic fibrosis, which does not allow the secretion of surfactant, so her alveoli are always at risk of collapsing, and mucus buildup is great and severe. So treatments include wearing a pulmonary jacket with vibratory motions to expel and break up some of the mucus. They show this vividly in the show. It's a very interesting show for that character if you want to kind of help this stuff stick better as far as why surfactant is important. It basically keeps alveoli from collapsing upon itself. This is just more minutia for you to read if you'd like. That's fine. So Laplace's law, basically what I just mentioned. I don't want you to memorize what Laplace states. Just understand that surfactant decreases surface tension. It's a secretion that basically leaves those alveolar walls intact during oxygen exchange. So basically, this is what it prevents. This is more high details into it. FYI, this is just minutia. The lungs. So I want you to understand that when we look at the lung, we need to understand that we always get that picture of the heart surrounded by lungs, and then we just understand that, okay, blood goes into the lungs, gets oxygen, goes back to the heart, goes out into systemic circulation. But here, I want you to understand where exactly this is taking place. So we have the lungs here. This is the hilum, the inner part of the lung. So there's three surfaces. We have your costal, which is corresponding to your costal cartilage, your rib cages, thoracic cavity, mediastinal portion is going to contain all the mediastinal structures such as the heart, and the diaphragmatic portion, which is this outline right here where the diaphragm is located. You can see here, this is where all those structures go through your pulmonary artery and pulmonary vein. There's three borders: anterior, posterior, and inferior. Excuse me. So this picture here shows basically if I were to have the lungs and the heart, my head is the heart, and we do this. I'm showing the inside part of the lungs. Notice the difference between right and left lung. There's fissures. There's particular called a hilum that I want you to get familiar with. There's a cardiac notch that basically shows you where the heart is going to be located, and the diaphragmatic surface is located. So these indentations you see here actually correspond with the shape of the diaphragm and the heart. You're going to have to get familiar with what's inside the hilum for the exam and for lab as well. Here's what the right lung consists of. Notice it's got three lobes divided by horizontal and the oblique fissures. This one's going to be shorter and much more heavier and wider than the left because it has an extra lobe, and also has more of the parotid structures on the right side of the body in the thoracic cage. Understand this slide very well and what it consists of when you compare it to the left lung. The hilum is basically what we're looking at right here, and I want you to understand where all these structures are located. Right, so we got the bronchus, right intermediate the bronchus as well, and we also have the great vessels that enter in this area as well. Okay, so understand the left lung structures as well. So you have to know the right and the left, the hilum, what it consists of, your left main bronchus, and the great vessels that are corresponding to this area as well. Alright, so the left lung is divided into two lobes, okay? The oblique fissures are going to separate those. Superior and upper lobe, lingula is basically segments that are going to basically outline here. Is the portions of the lung, superior and inferior. It's this little region right here, this little shape that basically outlines the lungs, just similar as like the cardiac notch and the diaphragmatic surface here are found within that area. So know all the structures within the hilum, know the lingula, know cardiac notch, know your diaphragmatic segment as well. So lingula is basically, it's found inferior medial. I'll show it to you in the next slide. My face is blocking it, but it's a projection basically from the anterior aspect of the upper lobe of the left upper lung cavity here. So here, let me see what I can do here. So here's your left lung, left upper lobe is all of this. So it's just a little outward projection of that. Let's see if in the next slide we can see it a little better. So yeah, so here's your left lung. So this outward projection here. It is your cardiac notch right here, and your lingula is right here. So that's where it's located. Notice the heart rests directly on top of the diaphragm, and how intimate the diaphragm is towards the lungs. Here's your right side as well. We actually do have this anatomical structure in the lab for you guys to practice on as well. Here's what the structures look like on the anatomage. Notice how well the thoracic cavity protects the internal organs in the chest. Here's the lobes with different colors. You can do this as well in the lab to allow yourself to get a better understanding of what these things are. So this structure here, This is sort of what I'm talking about, where I need you to understand where the main bronchus enter the lungs at the hilum. Here's an example of your ribs right here. And basically what consists of the parietal and visceral pleura. Visceral always means organs, so if you have a pleural space, we have your mediastinum right here where the heart is located. Here's your diaphragm. Lung is the organ, so it's going to be visceral. This is your visceral pleura right here, this orange like structure here. This over here is your parietal pleura, all of this stuff here with the blue line. Now we have a space in between here that fluid and air can get into and basically collapse the lung. So understand what each consists of. So in those bottom two paragraphs, I unfortunately didn't bold them. So understand that the visceral pleura consists of the serous membrane, which serous means serous fluid. It's like an amber tinged fluid that's secreted. Basically allows for lubrication to occur. When it folds back onto itself, it becomes a parietal pleura, which basically is going to encompass most of the mediastinum and other structures not directly related as an organ system. So get familiar with that. This is what the parietal pleura consists of. So if you can see here in this diagram, this whole area consists of your parietal pleura. And all those four structures found here in the slide. So from what all of this confusing stuff I just mentioned, just know that parietal pleura lines the walls of the thorax, and the visceral pleura surrounds the lungs. Okay. Notice that the parietal pleura does have some nerve endings, and it is sensitive to pain. The visceral pleura is insensitive to pain. So that's a big thing that you might want to know. But the pleural cavity, as you can see there, the parietal pleura between the visceral pleura is the pleural cavity, which is right here. You have to maintain a certain amount of pressure within that. It's called intrapleural pressure. It's about 756 millimeters of mercury. Anything that exceeds that, air or blood from a stabbing or shooting or blunt force trauma breaks through that parietal pleura and basically infiltrates that pleural cavity, is going to basically compromise and collapse upon the visceral pleura, making the lung parenchyma become destroyed and smaller. And this will appear a big black area on the chest X-ray. But yeah, this pleural cavity has to maintain a certain amount of pressure to stay open and allow for proper air exchange and expansion of lungs and costal cartilage. If there's any compromise with the parietal pleura, allowing any other substance, such as blood or debris or anything else, is going to create a compromise in the intrapleural pressure capacity of the pleural cavity and leading to lung collapse. We call that a pneumothorax. So that's just basically what I just mentioned. Know where the intrapleural space is located. This is what a collapsed lung, also known as a pneumothorax, on patient right would look like compared to their unaffected left lung. So you can see the visceral pleura is surrounding the entire lung tissue. The pleural cavity is surrounding the thoracic cavity. And that gray area is your pleural cavity. Notice that if there's any type of compromise to that parietal pleura area, a stab wound, anything that could lead to fluid, it'll just come, or excess air can come in there and basically destroy the entire lung and collapse it, leading to decreased oxygen exchange and transport capacity of the patient and difficulty with certain exertional activities such as walking or standing for a prolonged period of time. This is what it looks like here. You can barely, you can see here that this is your heart, obviously. This is your diaphragm. your costophrenic angle. Here's your spine, your clavicles, all your rib cage if you want to count them. But out here is your parietal pleura, this area over here. Your visceral pleura is basically, let me show you here, this dark outline. That is air getting in there, shouldn't be there. When compared to sides to each other, you can see all the normal pulmonary vasculature here, but it's absent on this side. That means air is compromising the area and starting to collapse the lungs. So it's probably an early, spontaneous pneumothorax happened spontaneously. Could have been from some sort of blunt force trauma or something sinister, but this line of demarcation is starting to begin. It's usually much more defined. I think in the next slides I have a better picture of that. So this we call a tension pneumothorax. Remember I mentioned in the first parts of class that air is black on x-rays. Anything that's not dense is black. Anything that's white retains the white color of the x-ray paper. That means it's dense. So bone or fluid or anything else is going to create this white so this is called a tension pneumothorax. So this is one side of his lung cavity is basically building a lot of tension with air and literally pushing all the mediastinal contents to the other side. This is an emergency. Usually have to do a decompression with a needle in this situation. But you can see all the vasculature here, the pulmonary system, and then complete darkness, a black void here. That is due to the amount of air in that area. This is a hemothorax, so you can see normal lung cavity presentation here in a way. Vasculature is normal. Here's your diaphragm, and here we have a line of demarcation, where the blood is located and has accumulated there in the left lower lung field. There's not much air in there. This person's probably going to be presenting with hemoptysis and difficulty breathing and pain. You can see the diagram here as well, how it looks like. So that'll give you a better idea of what the parietal versus visceral pleura looks like. Respiration, so the correct term that we use in medicine for inhalation is inspiration, and expiration for exhalation. Expiration can mean something else, like when the life ceases to exist, but for all intents and purposes, today's lecture, expiration will consist of exhalation or breathing out, and inspiration will consist of inhalation or breathing in. And when you write your notes, use these two terms, inspiration and expiration. But yeah, so it's basically moving air into the body and letting air out of the body. So this is a schematic here of how inspiration and expiration occur. So quiet inspiration, which is probably what's going on right now while you're sitting in class, is basically just consists of the diaphragm and the external intercostals driving that respiratory mechanism to allow you to breathe quietly. Okay, so if I were to ask you what structures are involved with quiet inspiration and exhalation, you're going to say the diaphragm and external intercostal muscles. Because you're just sitting there relaxing, you're listening to lecture, you're paying close attention to what I have to say, taking great notes. But yeah, so the rib cage will expand due to its costal cartilage insertions there to sternum, as we discussed in the last slide, at last PowerPoint. But yeah, so you understand what the diaphragm also does. During inhalation, diaphragm basically contracts or moves down to allow air to make room for air, and it basically relaxes. When it relaxes, it moves up into the thoracic cavity to help expel that air that or CO2 that just got filled up in there. So quiet respiration, the diaphragm contracts, as well as the external intercostal muscles. Those are the ones that are going to basically open up your rib cage. They're going to contract and allow motion to raise and relax. So when you raise, these external intercostal muscles are contracting, as well as your diaphragm. Everything the entire thoracic cavity will elevate, including the sternum. But this is what occurs in quiet breathing, quiet inspiration, quiet exhalation. The complete opposite occurs. Diaphragm relaxes, pushes up, Ribs lower, everything relaxes, and you exhale in that regard. Forced inspiration. For example, if I'm training on a treadmill and incline, that's creating more stress, more load, more resistance for you to walk against. Basically, I'm creating more afterload, so to speak. But that's just external. We'll discuss that later in cardiology. But basically, if I'm on a treadmill, an inclined treadmill, I'm being forced to walk at, let's say, 3.5 miles an hour with a 7% incline. That's going to be a lot of work for me to do. So I'm not going to just rely on my diaphragm and external intercostals to drive my respiratory drive. I'm going to need some help. So here is where your sternocleidomastoid, your scaling muscle group, and your pectoralis minor help to lift the thoracic cavity even higher and greater to allow for more air capacity to enter the thoracic cavity, more air exchange to occur, more oxygenation of tissues during your strenuous activity, and so on and so forth. So I want you to understand the muscles involved with quiet inspiration and the accessory synergistic muscles involved with forced inspiration, as you can see here. So with forced exhalation and expiration, just say forced expiration, that's basically what we're doing here. Your internal intercostals are involved here. So also these muscles, rectus abdominis, your external obliques, internal obliques, and transverse abdominis, which really rests right up against your abdominal organs, is going to be instrumental in forced exhalation. That's why then when you're doing, I don't know if any of you have done a stressful exercise, but when you're running uphill on a treadmill, and you breathe in for 3 and you force it out on 4, you're using all these muscles to help you do that, and that is in response to the workload that you're working against, which requires you to have more oxygenation of your tissues in order to continue with said activity. If not, you won't be able to complete the activity at hand. So this is a diagram showing you all the muscles involved with quiet inspiration, expiration, forced inspiration, forced expiration. This is basically what I just mentioned in the last few slides, but in a more concise diagram for you. So yeah, you might want to look at this or circle it or not. It's up to you. So oxygen, carbon dioxide, so O2, CO2 exchange occurs at the tissue level. So basically, we get air from the outside world. It goes towards the trachea, towards the larynx, to the bronchi. Then the bronchi, through all the terminary, secondary, tertiary, internal bronchioles, spread that air throughout each lung side cavity. Alveolar walls basically are going to be there to allow contact for the capillaries within the lungs to allow for adequate oxygen CO2 exchange. They're basically bartering. I'll give you CO2 for an oxygen, and then they'll go on with your day. They'll use it right away for breathing and then recycle, and then the next group comes in. All right. So understand where the pulmonary vasculature is located. As you can see here, the pulmonary artery. Notice the pulmonary artery is in blue, and the reason for that in all the diagrams is that it is carrying deoxygenated blood. So it's going to basically exit the right ventricle, go towards the lungs to get more oxygen in the pulmonary trunk, and then it's going to go down towards the other side of the heart and out the systemic circulation to oxygenate the rest of the tissues. So so know where the pulmonary arteries exit. They exit the right ventricle, and then you'll have to know where they go towards in the hilum of the lung in those previous images that we discussed earlier. So this is basically what I had just mentioned a few minutes ago. And here's a structure here known as the heart. So you can see here we have your right atrium, your inferior vena cava, and your superior vena cava is what's going to collect deoxygenated blood from the superior parts, your cephalad region, your head and neck. It's going to dump venous blood into here, and from your lower extremities, your one-way valves in your calves and lower extremities are going to push blood up towards the inferior vena cava. That is deoxygenated blood, might I say, into the inferior vena cava and collect into the right atrium. So that is what's happening there. So then we end up having oxygenated blood. It's going to go through lungs, get oxygen, and that's what the pulmonary veins are going to be the conduit of this oxygenated blood from the lungs to the heart. Um, so get familiar with the pulmonary veins, pulmonary arteries, where they enter into the lungs and where they are located, and what type of blood they dump into the heart or remove from the heart to go into systemic circulation. This is your time right now to focus on this and understand it, so that way if there's questions about this, you can answer them well enough. If you know the anatomical structures that subsequently in these steps, you'll be able to understand the physiology of the pulmonary cycle as well. So here's some more diagrams here. Right pulmonary veins, left pulmonary veins, located just literally on the posterior part of the heart. You can see the descending aortas back here. Excuse me. Yeah, so all the wording you see here. So I would know what vein, what artery does what. As you can see here, the right middle lobe is drained by the right superior pulmonary vein. Okay, so as we already know, superior, inferior. Okay, it doesn't have to be named that. You just have to know where it's located. Okay, now everything's going to be given to you. Right pulmonary artery, right pulmonary vein. So we have your right superior, which is superior. This is inferior, superior, inferior, superior, inferior, superior, inferior. This is entirely posterior and basal lung. So know that all pulmonary veins, which are left and right pulmonary veins, they all drain into the left atrium of the heart. Okay. Excuse me. The veins are going to dump oxygenated blood into the left atrium from the lungs. Bronchoscopy is basically this is what it looks like. This is what the inside of your trachea, your bronchioles look like, your right and left main. Here's your carina down the center. Bronchoscopies are done to evaluate any type of infectious or foreign body situation that could be present in the trachea. This is just to kind of give you an idea of what practically this information is used for. Um, the effects of aging on respiration. So as we age, the lungs are not as pliable as we were when we were younger. There's arthritic processes that occur at the costocartilage joints. Respiratory volume is going to be less due to the amount of fibrosis that can occur within the lungs. So if you don't stay active, obviously we won't be able to train like we used to when we were in our 20s. We won't be able to squat 500 pounds. We won't be able to sprint, under 5 seconds, 100-meter dash. We won't be able to do 37 pull-ups. We won't be able to do 200 push-ups, stuff like that. As we age, it just happens. That's what you see with professional athletes. They will eventually retire. When you get around age 35 to 40, you'll probably notice that their role on the team is not as that superstar status that they used to have. They can try and delay it as much as they can, but eventually father time catches up to them. Father time catches all of us, and we start to slow down. So we have to modify our activities at that point. Now walking becomes normal mode of cardiovascular exercise, and that's basically all we need at that point. We just need to stay moving and moving to keep those lungs working. The more we lay down, the more chances of you decompensating early or not having properly working lungs. The effect that, the term, if you don't use it, you lose it, really applies to this. So at least some form of cardiovascular exercise, or walking, cycling, some light weights. You don't have to do CrossFit. Just something to keep yourself and your lungs working to promote oxygen delivery to the tissues. So here's some landmarks that you might want to get familiar with to understand where things are located. I put these in to help you understand, basically correlate what we're discussing in anatomy to what you can find on a chest x-ray. I would kind of either print this or put a big circle around it or put it in our folder to help you study for the radiology class we'll be doing in the fall. There's another structure here, so you can see how things are in relation to the heart and lungs, and the diaphragm, and you can see here the stomach as well. But this is just kind of give you an idea of what to look for on a chest x-ray and what things are located. This is a lateral view of a chest x-ray. And you can find a pneumothorax. Obviously, you have a positive arrow sign here. But this is basically your visceral pleura right here. You can actually see it, that dark line there. All this stuff is just basically destroying the lung parenchyma. We have our normal lung vasculature up until this point where it completely cuts off. That means that the lung parenchyma has been compromised by air. In this situation, air is black compared to the other side. So cardiomegaly, it's a condition that can occur in dilated cardiomyopathy or congestive heart failure. There's also another condition called hypertrophic obstructive cardiomyopathy, where the heart muscle is so big, primarily left ventricle, that it doesn't allow enough space for blood to collect in there. It's basically doing a forceful contraction, but a little bit of blood's going out into systemic circulation. And we'll go over that in the cardiology section, but that has led to many athletes experiencing fainting on the court, on the field, and not recovering at all. But this is the true definition of cardiomegaly on a chest x-ray. It's cardiothoracic ratio. What I mean by cardiothoracic, the size of the heart, the size of the entire thoracic cavity. So if it's greater than 50% on the PA view, which is basically what you're seeing there in front of you, that's what's going to classify it as cardiomegaly. Left pleural effusion, you can see here that in the last slide, this was fluid or blood. But you can see here the entire right lung. Here's your parietal pleura and visceral pleura, basically intimate to each other. Here's your costophrenic angle. Here's your diaphragm. Here's your pulmonary vasculature, your heart, your mediastinum, your trachea, your spine. Your aortic trunk is right here. You can see that this entire area has been infiltrated by fluid, or this is what we call a pleural effusion. Basically, it's taking over the entire lung field. This is what's left for the person to breathe in. He needs to have a chest tube put in, get all that fluid out of there, and start some lung physiotherapy to kind of save what's left. Emphysema is due to smoking. You can see these ground pulmonary nodules and fibrotic parenchyma here in the lungs won't allow it to expand properly, decrease oxygen capacity. The person probably walk a few steps, will need a break. And this is what fluid in the lungs will look like, primarily in the right middle lobe. So this is called right middle lobe pneumonia. This is what it looks like on chest x-ray. So as I mentioned, anything that's black or dark has no density, so it would be air. But fluid in large amounts, a large fluid collection, such as you saw there with the pleural effusion, and here with the right middle lobe pneumonia. This is just to kind of give you an idea what we use this anatomy that we're learning today in a practical setting, and to kind of give you an idea of what to look for in the fall for the radiology class. That concludes today's lecture. Any questions, email me. Have a good day.